All right, so we have a little less than an hour. This will be interactive as much as you all feel comfortable interacting, mostly through the chat for now. Um, Karen will monitor the chat, and if you have any questions that need to be addressed at the time, she'll interrupt me. If not, we have a good 15 minutes to discuss. So as Karen mentioned, I graduated from Columbia School of Public Health back in 2005. And I spent the majority of my career since then working in hospitals and clinics. So I've worked at these hospitals that you see here. The Morris Heights Health Center, MHHC, is a federally qualified health center in the Bronx. I spent about 5 years there leading the Department of Performance Improvement. Went on to work for a statewide agency that oversaw all of these FQHCs, or we also call them community health centers throughout the state of New York. So there are 70 of these clinic organizations that operate 800 sites throughout New York State, rural and urban, and they serve over 2 million medically underserved New Yorkers. So New Yorkers who are on Medicaid, these clinics serve about 50% Medicaid and uninsured. I've also done some consulting work with Center for Care Innovations in Oakland, who also support these clinics in the state of California. And I currently work for an integrated health system called Highmark Health. So we are both a payer and a provider. And in all of these roles, I did performance improvement, quality improvement, where I was focused on improving better outcomes, usually clinical, but that's also could be operational, like delayed wait times that we've all dealt with in our personal lives. It could be patient safety issues. It could be financial, regulatory compliance. And in this work, I kind of realized that, especially in healthcare or different industries, we tend to rely a lot on methods to understand problems that are kind of rooted in different industries. In healthcare, we're still using methods in manufacturing. But as you all know, in the different startups and industries that you're working in doing social innovation, some of those methods don't always apply. And you also have to factor in complex human behavior. And so I started realizing in my work, in order to understand problems well, to be able to develop better solutions, you have to blend both a quantitative and a qualitative research method. And that's what I'll be discussing. One of the things I'll also share is that I do some independent consulting, and I've worked with a lot of innovators, startups, organizations also working on social entrepreneurship. And unfortunately, they reach out to me a little too late when their startups are struggling. So I'm curious if you could just put it in the chat. What do you think, or what do you know, are some of the common reasons for startups to fail? Bad management, cash flow, definitely. Yep. So I see a lot of you also talked about, maybe not understanding the market, not doing research properly. And you guys have, essentially answered the question. A lot of the entrepreneurs I have worked with, usually a year or two after they've implemented a product and nobody's using it, a lot of times it's because there's an absence of a product market fit. So in other words, as somebody put in the chat, they've tried to solve a problem that doesn't exist, or they solved the wrong problem, or the problem doesn't, the product doesn't really add any value to the people it was meant to serve. Sometimes there are poor marketing strategies, lack of user adoption. I read once that 80% of startups fail due to poor user adoption. I'm prepared for market changes, and then also pricing and cost issues. And the reason I And of course there were other issues as well, bad management, you may not have the right people on your team. But for the purposes of this presentation, I want to make sure that you all are equipped with some tools to make sure that you are understanding your market and particularly understanding your user so that you are solving the right problem for the right person. So these are companies that have hit the mark or hit the target. We've got Uber, we have Apple, we have OXO, we have Nike. If you could put in the chat some of the products that you have used that you cannot live without. Things that are value added, things that you feel like you can't live without anymore, that just make life better. Oh yeah, a lot of phones, computers, apps, Wi-Fi.
I like
Wi-Fi
that.
is like the lifeline now, right? Absolutely. Oh, Amazon, yes, especially during Christmas time. So I'm going to flip the question. Tell me about some products that you have started using and then you quit using them. Oh yeah, the different apps, planning. For those of you that had mentioned apps, can you put in a reason why they didn't add value or you stopped using them? What was that frustration or that pain point you felt? Too complicated, too many, complicated interface, not intuitive enough. On that point about intuitive, I often talk about our iPhones, or if you're, an Android user, that as well. We didn't get our new phones with this massive manual where we had to figure out how to use it, right? Apple has done a lot of work to understand their end user and to create a product that is so seamless and easy to use that a 2-year-old or senior citizen is able to figure out how to use it pretty seamlessly. And Apple is also that company where, right, we have products that we cannot live without. We cannot leave home without having our iPhones in our pockets or our purses. And in fact, Apple created the term user experience, which is the focus of this webinar. User experience is also called human-centered design and more of the social innovation sector. So thank you for those comments in the chat. So a lot of people think designers are, it's how, the prettiness of something, whether it's a service or a product, but a lot of it is really focused on how it works. And this comes from Steve Jobs. And I have a little image of the OXO version of the French press. So as I mentioned, OXO is one of those companies that use human-centered design in their products, which I happen to love. And if anyone has used a French press for coffee, one of the major frustrations is cleaning it out. And so they've developed this little silicone insert slip that makes it super easy to clean out that French press. Somebody at OXO had also watched their wife, who had arthritis, struggling with grip mobility, to use a can opener. So what the company did is they started observing the person using the can opener, figuring out those frustrations and pain points, and kept redesigning their can opener to make sure that people who had grip issues were able to use their product well. So the way they make these products seem so seamless and valuable to us is they collect the right kind of data. IDEO is a human-centered design organization. And the quote is, data by itself is not actionable. So we need to find the right kind of data so we're able to answer our core questions and get the right kinds of insights. And I'll pause here and say, I come from healthcare, which is very quantitative driven. It's very metrics. We love our numbers. We love our rates. That is not enough. Those rates will tell you the prevalence of an issue. It tells you what is happening and how much is happening. In the clinic setting, you will find out how many uncontrolled diabetics you have. It doesn't tell you why. Another example that I've been thinking about quite a bit is maternal outcomes for Black and Brown women. You can go online and find articles that tell you the prevalence of that issue. Not a lot of people are able to really explain accurately why that is happening. And if you don't understand why it's happening, you don't have a good chance of creating solutions that will actually work. And I love this slogan. There's different riffs on it, but the way you get some of that valuable, actionable data is that the people closest to the problem or the pain should be closest to the solution. So in the social innovation space where you're hoping to solve problems for the people or for the planet, you have to go to the people who are most impacted and treat them as experts in the problem that you're trying to solve. So the method of doing this is called human-centered design in our space. And there's 5 main phases of how we do this. And I'm going to just talk through the generic framework. I'm going to describe kind of a strategy of how you can do this. And I'll give you an example of when I've done this myself and some of the insights we found. So you always lead with empathy. You're centering on a problem that people are facing, and you get super crisp and clear as to why you're solving it, for whom you're solving it, and why. You always want to start any kind of research project with either a hypothesis or the problem you're trying to solve. And it sounds very basic, but I find so often people jump into solving something without having that anchor point of clarity. You need to go through and research the problem space. And as I mentioned, it's not just about your quantitative data. You need to also gather qualitative or experiential data from the people you're trying to serve. After you collect all those insights, you work to find themes. You prioritize them. Often with the problem, I've worked on problems where there were like 15 themes of issues. You cannot do all of them. You have a method of prioritizing the ones that you have control over that will actually impact your problem statement. And then you figure out in a very optimistic way, like, yeah, these are problems, but how might we solve these problems? There's always this optimism that there is a solution out there. And then you lead into a prototype scenario where you've got to be scrappy. You need something where it is fast and easy to fail. You want to be able to find issues in your product or your service idea where you haven't invested too much time. It's just good enough to be able to put it out there in the real world and test it with your users in the context of their life so you could see if your product is seamless, easy to use, reduces any frustrations, and catching the things that they get tripped up over that are confusing that you can then go and fix. And I find people have a hard time with prototyping and the good enough idea. But as I said, if you get too deep into creating a perfect product, if you do test it and you get feedback that's hard to hear, I find entrepreneurs will just push forward and then blame the user for not using their product well, instead of having a product where it's you're still in an agile phase of development where you can make those tweaks. And you can do this phase or do this research at different phases. So I understand this audience might be at different parts of their startup. It's always best to do this when you have an idea. Don Norman from Apple has a famous quote in the user experience world: "You are not your user." And because you came up with an idea doesn't mean that the product or solution is going to work for other people. So you need to make sure that people actually need and want it. So that is your market fit. You go out there and you build, again, scrappy prototype to just figure out, is this desirable by people? Is this actually feasible to build? And is it viable? Is it financially sustainable? Can you scale it out? You need to put it out there in the market and see if these three elements will come to fruition. And then after you've built it, and understanding many people waited until they built it, you still should go out there and have your users test it out and give you feedback. So many of the apps that we just mentioned in the chat, they go through iterations and upgrades. Those are typically based on user feedback on any glitches or things that need improvement. So if any slide is something that you might be able to use and refer to, I would recommend this one. You always start with that anchoring research question, like, what is it about your product that you want to know? And this is important because when we don't think about that research question, we often go in with assumptions and guesses, and those are riddled in bias. Again, kind of leaning on my healthcare experience with, say, patients who don't take their medications. There is an assumption that people are just forgetting or they're careless. And so we put in inappropriate solutions to say, well, they need to be educated. But what if our research question was, why don't people take their medication? That's reframing the problem in a way that's a lot more interesting and more likely to lead towards solutions that will work for patients. You come up with a discussion guide. So you think about, well, if I'm curious to figure out why people are not taking their medication, like, what are some non-defensive questions that are open-ended that will help me answer that research question of why people aren't taking their medication? So I'm going to pause and ask in the chat, how many people do you think need to be interviewed for a research study such as this? Right? You're tasked with figuring out why people are not taking their medication. You want to talk to some people and to figure out why. What is that sample size? Wow, 100, you've got 10, 150. Okay, I'm glad I asked this question. What is a population size? So I see we have a lot of academics. So this is something that creates a lot of confusion and tension, to be clear. So you only need 5. For a particular user group, so say we're looking at, 1,000 for consumer goods. Christina probably has more resources than most of us. So 5 is surprising, I agree, Mina. So if you think about academic research, and I've also worked with a lot of clinicians where they are used to very expensive, large-scale longitudinal studies where you have large sample sizes, where you might have a control and intervention. You're able to take the statistically significant findings and generalize it to a larger population. That is a kind of research method that works for a different kind of problem. If people in the innovation world use that same research framework, competition would bulldoze them over. startups do not have the time or the money to be able to spend time researching hundreds, if not thousands of people to figure out information about their product. And what studies have shown, and what I've experienced in my own consulting work, is 5 people of the same user group. So maybe it's 5 diabetics, or maybe you want to look at 5 diabetics in an urban area. Maybe it's 5 diabetics in a suburban area. Your different groups of users are kind of based on different needs they might experience. 5 people will identify 80% of your issues. And any more than 5, you're going to see a diminishing rate of return. I worked with a physician who developed a platform, and she didn't believe the 5. So I interviewed 20 people, and sure enough, it was wasted time and money because what we saw were the same patterns repeating themselves. 5 people gives you a really quick, rapid cycle of getting feedback to figure out what it is that's frustrating people about your product so you can go back and make refinements. And if you have more resources and time, you can go forward with that. You could always try 5 and just see what's unfolding. And if you realize that there are insights that you want to dig deeper into, you can, by all means, go find more. And while I have always gotten a lot of pushback on the 5, I'll also say maybe 5 is still better than not doing any. It's a lighter lift, and you're still going to find some interesting surprises, which I will show in my real world example. So after you find your 5 people, you figure out, well, where do I find them? How do I interact with them to get those insights? You document them, you find your patterns, and then you prioritize which actions you're going to move forward into development. The hardest part about this process is actually asking people. I find as adults, we have lost that childhood ability to be curious and ask a lot of questions. I think as we get older, we are valued for knowing answers and providing those answers quickly. And we're also worried that if we ask questions, we're undermining our own expertise and authority. But the whole point of this exercise is that you're the guest. And you are, inviting somebody to explain to you kind of their lives, their experiences, their needs, their attitudes, their beliefs. And you are simply there to maybe talk 10% and to have the other person speak 90%, because they are the ones with the breadcrumbs or the clues for you to really get the answers to what you need to know about your product. I've often found when I do workshops on human-centered design and I try to have people role play, they get stuck and uncomfortable. But you can see that these prompts kind of help generate a smoother conversation where the person you're interviewing is treated as though they're the expert in their own lives, which they are, that they have valuable insights, and that you're sincerely interested in what they have to tell you. And this is a great book, and I found that as an adult, I've had to read a lot of questions or books about asking questions. But there's a phrase called humble inquiry. It's a fine art of drawing somebody out, asking questions to which you don't already know the answer, and building a relationship based out on curiosity and interest in the other person. So I'm going to walk you through kind of a real example of some consulting work I did in California. And in California, they have community health clinics where a majority of their patients, right, Medicaid, uninsured, racially, ethnically very diverse. And they were interested in working on health inequities as it relates to telehealth visits. And in particular, telehealth, right? There's telephonic, which is over the phone, and then you've got televideo. And televideo is a lot more interesting in terms of being considered a higher quality modality of remote visits because you can see the person face to face. So what we did is we started out with a research question, and you can have many, but this one is geared towards physicians and trying to figure out, well, why aren't physicians using televideo visits with their patients? This was last year. So through the pandemic, clinics had already put in the infrastructure. Televideo visits were part of their protocols, but people weren't using it. And the idea was that, well, if you offer televideo visits, you're improving access. So why is it not happening? Collected quantitative data, pulled monthly reports, and we're able to see that those video visits were still pretty low. So the discussion guide, and again, I worked with clinical staff to figure out, well, how, like, I don't want to just go to a physician and say, well, why aren't you doing video visits? Not only are you going to not get a rich depth of responses, that creates a very defensive dynamic. So instead, we create very open-ended, curious, empathetic type of questions. The more open-ended, the more insights you're going to get. I think about it like a funnel. If the mouth of your funnel is your question, the wider it is, the more interesting insights you're going to get. So you can just ask, like, describe the last video visit you conducted, and say with the non-English speaking patient, what was that like? Can you describe what happened? What would have made that experience better? The staff found physicians, you want to think about screening the right kind of person. These are the people targeted for your research. So physicians who see patients for services that could be done virtually, right? You don't want to talk to surgeons or physicians that have the kind of care where it must be done through a physical examination. It just would not be relevant. We find 5 physicians, and then the staff had to think about, well, where do I find these physicians who are super busy? Well, we know that there are meeting rooms or break rooms, routine provider meetings, or maybe they can even observe one of those remote visits with permission, of course. They nominated a person to kind of ask and observe physicians those discussion guide questions. They documented their insights in a way that works for them. They then had to look to see patterns and figure out which of those patterns they wanted to solve for. So I'll ask you again in the chat, what do you think were some of the responses by physicians as to why they were not doing video visits? Now get a comprehensive examination by video. Yep. Awkward, trouble understanding accents. Yep. Oh, interesting. Yeah. Physical metrics are hard to measure. Yes, we talk about remote RPM, remote patient monitoring devices. Legit professional enough. Yep. Inexperience with technology. Yep. Afraid of technology, worried about privacy. Yep. These are great. Emotive senses. Well, I would love to show you the things that our staff found when they used human-centered design to try to understand why their data reports with low video visits was the case. So this board with the sticky notes is a very classic human-centered design way of collecting insights. You put one idea on a sticky note. You could do this physically in the real world, or there are online platforms like Miro, Miro, or Mural, Murl, or even you could do a PowerPoint or a Google Jamboard, depends on your resources. So what this group did is they went and interviewed 5 physicians in their clinic. They asked those open-ended discussion questions. They collected their insights, and we grouped them into clusters or themes. So here we go. And I'll say that, while this, we put in telehealth to increase access, we actually found that by design, we were widening the equity gap. So what they found was that with older folks, there is this belief that physicians had that they're not tech savvy and that they probably wouldn't or couldn't do telehealth. Physicians felt like patients on telehealth are just too distracted. We're always multitasking. The doctor said, I can't count how many times I have a patient who's taking my video call at a drive-through. Some of those physicians did want to see their patients in person for some of the reasons you mentioned in the chat. But there were also a lot of insights around time, which we all know is an issue in healthcare. One doctor who is a mental health provider, he said, I probably shouldn't say this, but it allows me to type my notes while the patient is talking and the patient doesn't know. So while we promoted video visits, his staff were doing phone visits, even though that was not considered the best standard of care, because it saved him and his staff time of not having to do documentation after the fact. Also feeling like, hey, you only have 15 minutes for a visit, but to set up the video visit takes 5 more minutes than they had time for. And then we want to talk about the linguistic challenges for patients that are served in California at community health clinics. A lot of the clinics were serving Asian and Hispanic populations, but the doctors felt like, well, if patients need translation needs, that's a complex workflow. Do I call in a language line? Is a language line part of the video visit? And also realizing linguistically, one of the providers who spoke a Chinese language said, I can speak medically to my patients in their language, but I don't know how to explain certain technology terms like URL. Video visit instructions are often not in a patient's language. When a patient receives a text or patient portal message to click on the link for the video visit, those are often in English. So you could see some user challenges, both from the provider and the patient side. A few of you had mentioned in the chat around technology. We assume physicians and perhaps physicians of a certain age to be tech savvy. Physicians are focused on the medical record system. They may not be used to Zoom or have the workflow of a video visit. Often with training with providers, it's one and done. Here it is, and you're left alone. That's often not good enough. Also with training, somebody had mentioned about, maybe feeling like a full examination is important, but there are actually a lot of visits that can be done remotely. I worked with a clinic who did women's health. You're like, well, how can you do women's health virtually on a video visit? Well, sometimes it's a consultative visit. It's discussing labs. It's maybe breastfeeding classes. maybe it's a depression screen. So really helping providers understand what is within like safety guidelines to do remote visits. But that information also has to be communicated to their support system. Provider said, well, I know I could do some of these visits remotely, but the schedulers keep scheduling in-person visits, and I don't know why. So schedulers didn't know when to book remote visits. Schedulers also had never been trained on video visits, so they didn't know how to answer patients' questions about how to conduct one. So it was just easier not to offer. Too difficult for scheduling for doctors to switch from in-person to remote. Not only was that a different mindset and workflow for them, trying to find the space to do different kinds of visits was not always feasible. Sometimes technology didn't allow for doctors or schedulers to select a video visit. They weren't sure, there was no digital or telehealth feasibility screening for patients. Do patients, A, want to do a video visit? B, do they have the Wi-Fi or broadband to do video visits? And C, do they have the devices to be able to do a video visit? So if you don't even know which patients are willing and able to do a video visit, that's kind of a starting point that you miss. Sometimes the clinics have issues with connectivity. One of the surprising ones was the doctor said, well, my medical assistant or patient care technician doesn't set it up for me, only to find out that that medical assistant had never used Zoom and didn't know. So there was an assumption that the medical assistants were young, that they should just know how to use Zoom. But if you haven't had to use it in your personal life, as we all do on a daily basis, that assumption led for lack of training for the support staff. A lack of private space to do video visits. Doctors weren't always allowed to use quiet exam rooms because those are meant for in-person visits, but they also couldn't do video visits in their break room due to privacy and noise. So there you see an infrastructure issue. And I saved my favorite one for last. One of the reasons a doctor said that he or she never does video visits is the tablets were never charged in the morning. And if you think about if you had never asked that doctor why they don't do video visits, that is such a simple solution that could have really helped supported that provider and the patient who could have benefited from having a different kind of access. So all to say, if we had just run data and made assumptions both by doctors and patients, we would have missed that there are a lot of simple solutions that were quite easy to fix. And some of these are free to fix. And I find this time and time again when I use human-centered design with entrepreneurs or innovators, is that often they don't ask the questions because they're afraid that they will get answers that they don't know how to fix. And in actuality, whether it's been around COVID vaccines, telehealth, staff satisfaction, reasons why patients keep going to the emergency room, I have consistently found things that are very simple that would really make a lot of difference for the people you're trying to serve. And I also want to add a point. There was an early chat, just kind of making sure that you're also working to bring in the voices of those that are underrepresented. When you design products, you may unintentionally be creating inequities with the way you design them. So with telehealth, we are putting in some complicated technology that's hard for patients and providers. They're in languages that people don't always understand. People, depending on their level of comfort with technology, may need extra support. With the older folks, where we assume they are not technically savvy, I always say we all have older people in our families that are addicted to Facebook and YouTube. They know technology, they rely on technology. Asking them to set up a video visit and trust a link they've never seen before is a different kind of education support that they need. So I encourage you all to also think about, as you're designing your product, who is it for and who is being excluded by the way you're designing it? And, I'll just breeze through this. I really wanted to focus more on like setting you up to understand how to conduct your research. But once you find those patterns of insights, you kind of go through a method of saying, I'm going to vote to work on this one pattern of, say, let's say we're going to work on scheduling, and we really want to improve how schedulers are supported in providing video visits. You're going to take that and you're going to prototype some ideas. You're going to test it out with the schedulers, with the providers, with the patients. You only need 5 schedulers. Probably can find them at the front desk. You'll come up with some discussion guides that can be a blend of observing them as well as talking to them. You'll document the things that they're telling you. You again affinitize and prioritize which one that you want to move forward. So let's say you figure out that they have no way in the electronic medical record to select video visits. You're like, that is a problem I'm going to solve. I'm going to try it out and actually go back and test it with the schedulers to see if that actually made a difference. And I apologize because I was hoping to give you 15 minutes, but we have 11. And I would love to know if anything here resonated or if you have questions that you would like to ask. Or rather, what questions do you have?
I saw a question in the chat earlier, so I'm just going to read it to you. This goes back to, needing a sample size of 5. So the question is, if you're at the idea stage or you have a concept, is 5 enough to really get some feedback on your idea?
Oh, that is such a good question.
Yeah.
I'll give you an example, and I believe it is. And you can consider the 5 as a place to start. And if you're not comfortable with the findings, or maybe one person says something where you're like, I need to investigate that further, you can do another round. I worked with a physician who took a year off of her salary job to create a platform for home health aides or caregivers. She herself had family members in the field. She recognized that this was a really demanding field for particularly women of color. And she was hoping to improve their economic security by making it easy for them to find jobs. She had not tested her idea out. She had built a rather complicated tech platform, hired a developer, and found out later through my work with her that caregivers actually didn't have a hard time finding jobs. And we realized through those 20 interviews, because she wanted to do more than the 5, giving a physician and a focus on large sample sizes, that caregivers were using Craigslist. They were on Craigslist on their phone when they were taking the bus home. And that often, like when projects would end, say patient no longer needed them or they passed away, there were always other projects in the pipeline for them. So I think if the entrepreneur had at least done 5 interviews and talked to caregivers around their experiences of being a caregiver, I kind of challenged her to say, let's not just ask them why they're not using your website. Let's figure out why they went into the profession, what they love about it, what are they challenged with, what would make their lives easier. those first 5 people, 100% would have said, no, it's pretty easy to find jobs. And I like using Craigslist and I can do it when I'm on the go. But they said that they were challenged with, right? Because we asked that like broad funnel of open-ended questions. They were like, I really like it when my employer gives me professional training. Um, One caregiver said she had to figure out how to place a catheter on YouTube, which still horrifies me, but it indicates through that open-ended kind of fact finding that there was another pain point that we hadn't realized. And from that, the entrepreneur, 2 years later, pivoted and started creating a business with online training modules that long-term care facilities could then use to train the caregivers. So not only does that provide quality of care for that long-term care facility, it gives caregivers a sense of professionalism and confidence in their work. So I do believe 5 was enough. As much as you're, again, confident in the responses you're getting, if you feel like they're consistently saying the same thing and they do represent your target population, I think it's good information to go on. You could always then maybe create a rough prototype and put it back out with 5 different people and see if they would say like, yeah, this would be useful, or this is confusing, or I have something else I prefer to use. I'm open to anything else. I know that 5 sample size always confuses people. One thing I can recommend that I've done is I have put the insights from talking to 5 people on a Google Doc that I share with the person. And then I will, if they have the money and the time to do more, I will offer to do so. The money comes from providing incentives to the people you're speaking with. And our time is as, if not more precious. And I waited for the entrepreneur to see that there was a pattern that was repeating itself until she was comfortable with saying, nobody wants my product. But then she pivoted.
Thanks. Tenzin has a question.
Yeah, hi. Thank you for today's presentation. It's a very, maybe it's a fundamental basic question. So it's about the distinction between social, the audience.
Mm.
Okay, so let me back up. So there's social entrepreneurs and then there are entrepreneurs, right? So when we're talking about human design, what is the distinction for a social entrepreneur to understand who's doing something for social change as opposed to an entrepreneur who's not doing something for social change? And what is it about? So that's on the business person side, but then on the receiving side, the audience, the users, the customers, like what is that distinction in their experience? Um, or there is no, or maybe there's just no distinction. I'm just really curious about that because I think it takes a very spiritual person. When I say spiritual, I don't mean religion. I mean, with it's a kind of heart, a kind of empathy for humanity to go through so much effort and time and mental anguish to do a social entrepreneurial work, right? So, yeah, what is that distinction in how we design things? What is that thing that we can consider that's different from the way like a business student is trained to do corporate marketing I have a business background. I've worked in marketing. I'm in a completely different field now, and I'm considering entering the psychology path. And so, and I've had clients, marketing clients too. And so it's always something that's been on my mind. What is that distinction? Yeah, for human-centered design.
Yeah,
Yeah.
that's amazing. I mean, right, human-centered design in the social space or user experience in the tech and product development. And, this method was really meant to get customers to want to buy your product. Right, it came from Apple Technologies and they're killing it. In the social service space or the human-centered design, I mean, one thing I struggle with on almost a daily basis, because I now work for a for-profit company for the first time in my career, is this idea of return on investment, ROI. So, I think about, for the people you're trying to solve for, and also at the company level, like what is value? Like what matters to the people that you're trying to impact? And in the corporate world, it will be revenue. In the nonprofit world, it can also be revenue. We say no money, no mission. But I think the way you measure your return on investment for a social venture is going to be different and maybe not always measured by money. And if it is going to be measured by money, because you're entrepreneurs and you should be compensated for the work that you're doing, your return on investment or your financial success may not be as direct as dollars earned in a 12-month time frame. It might be less direct, and you might need a longer runway to see that investment. And the reason I say I struggle with this on a daily basis is in healthcare, you sometimes need a longer runway if you're trying to help somebody improve their mental well-being or physical well-being. You need to have an environment or investors that are willing to measure value and ROI in a way that's different than the corporate world. I hope that's helpful. And when I say, thinking about like what value means or the what's in it for me, if you're also appealing to say foundations or philanthropy, is thinking about like, what's important to them and how can your product support the mission of what they're trying to solve. Those things need to be aligned.
And we have thank you for that. We have some other questions in the chat. Maggie asked if you've ever run into heavy pushback from your proposed improvement. And, maybe you can share if that happens and how you might deal with that.
Yes. One of my early, I think it's often when I've been asked to do a research project and I come up with a solution that's different than what they wanted. So again, at the idea phase, I was working for an education nonprofit who wanted to figure out why students in the 5th and 6th grade were dropping out of school. This is in Nicaragua, Laos, and Guatemala. And they were very invested in the idea of giving backpacks with school supplies and uniforms. They went in again with the assumption that people were not going to school because they were embarrassed because they didn't have a school uniform. I did some extensive research and realized each of those countries had different needs. It was different by country and it was different by gender. And so what people needed in, say, Laos was safe transportation, especially when girls hit puberty and parents are worried about their safety and getting pregnant. So, my proposal were things like safe transportation, like a bus. In Nicaragua, it was a conditional cash payment. Parents were pulling their kids out of school so they could go work in the market or take care of other children in the household. So if you use a conditional cash program where you get cash to offset that economic loss of putting your kid in school, but it's conditional upon the kid going to school, that would have been the solution that the people closest to the pain said would have helped. And they just decided to not proceed forward because it wasn't this tangible backpack with their logo. But, at least I saved them a lot of money and resources from trying to solve a problem that didn't exist. So, and if people have an idea that they want to propose that's different than what I came up with, I'll always feel more confident when my research is based on what people told me they need and what they want. But, oftentimes a company has to balance that with what is considered like what can they afford and what's easy to implement. And in those situations, then I try to say, well, based on what your needs are, here are some recommendations based on what people have told me they need. And any recommendations workbooks, I'll offer 3 companies, Nielsen Norman Group. Nielsen is, you've heard of the surveying company. Their website, they send weekly newsletters. Those are great, quick videos. They do have guides. IDEO is a great organization. Acumen does social innovation using human-centered design. They also offer free courses. I think some are paid. And those are 3 that I consistently lean on.
Thank you. Thank you. This is really great. Really appreciate that. It's very, very useful information. And I think that number 5 is going to stick with everybody who is here. I've done research, and even I would not have, selected 5. So it's really good to hear that. Are there any last questions? We're a little bit over time, but if there's another question, and Sonia can stick around a few minutes to take that. If not, thanks for attending. Thank you. Oh, there is a question. Okay, Christina. Oh, you're clapping. Never mind. Thank you for coming.
Thank you
Thanks,
all for your
everybody.
participation.